development in Kenya. Now, this paper or this study is not an empirical study. It is more of a research agenda paper. It is work in progress. We've just begun. So we are yet to collect the data and then present or write an empirical paper. Now, basically now it's more of a roadmap on the way forward. It is actually a work of a group that is researchers who are actually a network we call Africa International Collaboration, focusing on global health security, but now using the ICT to come up with interventions that will help build resilient health systems in Africa. Okay, the motivation or a problem area. The recent COVID-19 pandemic increased the poverty levels in Africa, and the constraints or the limitations of the health infrastructure in Africa actually became more evident, was magnified, and it now attracted the attention of our team to be able to look into that and ensure proper preparedness in the future in terms of the intervention that we come up with. Now, in particular, the health information is not consistent with the needs of maternal and child health services in Kenya and actually Africa as a whole. In other words, the health information systems in Africa are deficient, that they are not able to support the health information needs for the various actually stakeholders in the healthcare space. This is even the health practitioners. We are talking about the patients who are citizens in particular. All stakeholders don't have access to adequate information to be able to make better decisions. And that's why in the event of acute public events like COVID-19, we are not able to really respond appropriately. So now, despite the declining ratios in terms of maternal mortality, there is still a challenge, because even the cases of maternal mortality that we have is as a result of lack of adequate information, because then there is poor diagnosis, because at the point of care, there is no adequate information to inform the caregivers to be able to make the correct maybe diagnosis and all that. Then we have even the mothers themselves. Pregnant mothers and lactating mothers don't have the right information to be able to manage their health well. Things like danger signs during pregnancy, things like diet, the right diet, the kind of exercises that they need to undertake in order to keep fit and all that. So the objectives of this study is to obtain a commitment of Global South and the Global North ICTD for development, researchers, scholars, and practitioners. Basically, we have researchers from Africa and also from the Global North, and specifically in the UK, working with the University of Leeds, universities in South Africa, that is Cape Peninsula University of Technology, UNISA. In Kenya, we have Strathmore University, and we are now extending to Ethiopia, University of Addis Ababa, and then we have also University of Ghana from West Africa. So we want to work together so that we can have proper regional representation in terms of Africa, regional representation, so that when we are talking about coming up with resilient health information systems in Africa, then we have a balanced or a regional balancing with the researchers from all these regions. And then compare notes with the researchers from the Global North and specifically the UK, so that then we come up with more hybrid solutions that we think will be able to change the situation in Africa. Now, number two, to identify ICTD for development gaps in the Global South, specifically Africa, Sub-Saharan Africa, to sensitize person-centered maternal and child health information systems. Why person-centered maternal and child health information systems? Because mothers and children are the most vulnerable. At any given point in time, in the event of an acute public health event, these are the people who suffer most. Why? Mothers have to take care of the young children. They have to breastfeed. So they are vulnerable as opposed to other categories of the population, like men and all that. Young children, you know, they are vulnerable, malnutrition and all that. So there is need to focus on this particular group and come up with interventions that will help improve the health outcomes for this particular group. Number 3, to propose a person-centered maternal and child health information system framework as a social design pathway for sustained Africa health security using Kenya as a springboard, ICT for development case. Now, in Africa, we have tried to digitize our health information in order to be able to be well prepared, to have adequate information in order to respond accurately or appropriately in the event of a pandemic like COVID-19. But unfortunately, we are still far because we have data silos. Our health systems are not well integrated. We have heard about interoperability, issues of interoperability of health data and all that. Now, what we are looking at here is that how can we achieve person-centered health information systems? Because it is one of the global policies by WHO that member states should adopt people-centered healthcare systems. Now, we know that person-centered means that you have to come up with solutions that are tailored to people's needs, right from the individuals to the community, to the national, and to the global level. If at all we have to succeed in managing the healthcare services across the board. But now you realize that we have context issues, variation in context. If you go to Europe, of course, you realize that the context is different in terms of infrastructure, in terms of literacy levels and all that. Coming to Africa, you realize there are differences, even in terms of culture and all that. So that's where we are talking about the people center, so that then we use methodologies, appropriate approaches that will ensure that we listen to each and every person, every stakeholder. When we say person-centered, we are not only talking about the end user, we are talking about even the stakeholders, the partners, everybody who's involved in this space. How do we have interventions that will meet the needs of these people? The health practitioners to be able to deliver health services from a point of understanding, making the correct diagnosis. They really need to have the right information. Otherwise, there have been errors, medical mistakes, because at the point of care, the health practitioner does not have the right information. So that's where we want to understand what are the needs of each and every stakeholder in the healthcare space, so that when we are designing these interventions, everyone is comfortable and that this intervention meets the information needs of this particular stakeholder. Now, the methodology, the research approach or methodology, we are proposing the core design methodology and the participatory action research so that we can be able to meet the research objectives that I've just stated. Core design is a design thinking, of course, method that embraces each and every stakeholder's ideas as far as the solution is concerned. Unlike in situations whereby we come up or there are foreign designs or proposals that we just implement, not knowing or being conscious of the fact that contexts vary. So if we use co-design, that means we consider the views of each and every person or stakeholder group that is involved in that to ensure maximum impact. Once we implement, then everybody will embrace that and use it. I give an example of iron supplements, which are given to pregnant or expectant mothers. Like in my country, in Kenya, most of them don't use them. They go to the clinic, they are given those iron supplements, they throw them away, they go home. And at the end of the day, you realize that there are still challenges. That's not improving the health outcomes. Then you try to find out, then they say, wow, they are too big to swallow. I feel dizzy after I take them. I find them uncomfortable and all that. So, and remember, this is an intervention which has been recommended by the WHO. Now, coming down to this particular individual in their context, in their situation, in their community, we really need to be very careful how we design these interventions so that then they are embraced and actually used by all the people who are involved in that particular space to ensure that we improve health outcomes. It will be a waste of resources, waste of time, waste of effort, waste of energy to come up with interventions, and yet the people who are supposed to use them are not using them because they have not probably been engaged, involved in the process of designing them. Okay? So the same thing with the ICT interventions. We also need to contextualize them to listen to the voice of the people involved. That's why we use core design. Of course, participatory action research, the same thing. Let them participate in the process, then to ensure sustainability of the solutions that we come up with. Now, these approaches are meant to facilitate also transdisciplinary African maternal and child health research. Transdisciplinary means that we are having experts from different domains. We have public health officials, we have medical doctors, we have ICT experts, we have social scientists coming together and working towards coming up with a solution which is balanced, so that the views of all the people are taken into consideration, then to enhance actually sustainability. Okay? Then 5 focus group discussions or workshops were used to formalize the identifications and proposed engagement of stakeholders within maternal and child services from poor, urban, and rural settings in Kenya. So basically, we had focus groups basically to brainstorm what are the issues, could be the gaps that we need to address going forward so that the future interventions are balanced, that those gaps will be sealed by those particular interventions that we are coming up with to make sure that we strengthen our health information systems. Now, the major outputs, one is to obtain commitment of Global South and Global North ICTD for development researchers, scholars, and practitioners. Trying to accommodate everybody, reason together, have different stakeholder groups coming together and working within that space to ensure that we are moving in the right direction. So the thing here is that having the researchers from the Global North and the Global South to compare notes, to brainstorm together and have a roadmap on how to conduct these studies, how to implement these interventions and all that, so that we can have a balanced view in terms of how we are going to implement this. Now, specific aspects under this is that gaining insights into the lived experiences. If we want people-centered or person-centered interventions, then we must understand the lived experiences of the people who are going to use that particular intervention, because contexts actually vary. Next is researchers co-created primary data collection tools for the purpose of engendering decolonization of knowledge and the promotion of equity and inclusivity in providing ICT solutions. You know, co-creation of knowledge is very important. Co-design and all that. Creating data collection tools in agreement. Deciding what kind of questions that we should use to be able to prop the kind of information that we want to gain inside the lived experience of the people in a specific context. Then the last one is that as a way of reflection and co-creating knowledge, engaging stakeholders. All stakeholders have to be, again, for purposes of sustainability. Now, we have the framework of person-centered intersectionality and the decolonization of context inquiry. So you can see we have the current situation. We have to look at the current situation. And then once we look at the current situation, have an understanding of exactly what is happening there by engaging all stakeholders within that context, then we move now towards a what can I call it? Co-design. We move to co-design now. After we have the baseline of the issues at stake, at the hand, then we move to co-design. We involve everybody now to try to design the intervention. And then, of course, eventually, we move now to, of course, deployment and measuring the impact, whether we have achieved our goals, our objectives, or not. Then the next outcome is to propose a Kenyan social design pathway for communities of paternal and maternal persons. One, to visualize the level and the impact of gained capacities and the divine connections and interactions with agencies and project levels. Established topics not discussed in depth in Africa are regarded as key value drivers of transformation for Kenya's ICT for development. And these gaps are lived experience has not been taken into consideration. That's to have context-specific solutions. Implementation of ICT solutions in terms of context. Then access to maternal health information. And lastly, health information competencies. These were regarded as the value drivers that have to be taken into consideration to have person-centered interventions. Thank you. Then now, again, we have now a Kenya social design pathway for communities of paternal and maternal persons adopted. So this is basically now going to be the game changer. We want to conduct our study to ensure that it is in line with this. So you can see the range of lived experience, and then we have the range of implementation, which means that we are beginning from individual level. Then we move up. That is now project decolonization. The methodologies we use there, we have to ensure that they are actually context-specific, get information from in terms of lived experiences. Then now, there is also the health system, health information system. This is actually adopted from the health information system for health security. That's the WHO health security framework, which then has to be contextualized within Africa, okay? We have to contextualize it. And then, of course, up there, we have to look at the culture of the people in that particular context, because culture is very important. You cannot come and force something into people without actually trying to understand their culture and see how you can navigate the space to come up with the interventions that can be accommodated within that particular context. Then, of course, we have the lived situation. Then, of course, community. Then, if you look at that, then you will see a response, intervention, transition. Then, in the last column, we have sustainability, activation, and transformation. Okay? Then I think let me talk about the conclusion. Contextualizing this research within the COVID-19 pandemic impact on Africa allows for discussions and the intersectionalities of maternal and child gender, race, social, class, and disability, focusing on domains of lived experience, implementation, and access to health information and health information competencies as key value drivers of change and transformation for Kenya's ICT for development. So ICT is good, but we have to be careful on how to implement it by taking into consideration the context within which those interventions are to be created. Thank you so much, and that is the end of my presentation.
Thanks, Danny, for your very enthusiastic presentation. Can you tell us a little about what engagement there's been to date with the Ministry of Health in Nairobi and with county-level ministries of health, and which counties you've been looking at? Thank you.
Okay. As I mentioned, this is actually a presentation from what we call Africa International Collaboration. It's a research network of academicians from universities in these countries now. Basically, we have, from Global North, we have the UK, and specifically University of Leeds. Then here in Africa now, we have South Africa. We have two universities. We have representatives from two countries. Actually, Dr. Mayowa is one of them, from UNISA, that's University of South Africa. Then we have CPUT, that is Cape Peninsula University of Technology. We have also a member of the team from there. Then in Kenya, we have myself from Strathmore University. Then we have also from Ethiopia, University of Addis Ababa, and then from University of Ghana. yeah, so we are still extending and expanding our network because we are focusing on trying to come up with interventions that are suitable for within the African continent. So the list is, we are still collaborating. We are trying to get more people on board.
I think that's very welcome, but I think it would be very interesting for you to try to engage with the ministry at a policy level in Nairobi, and then maybe pick a county where you know people who know you. You know, and there's a couple of counties around Nairobi where you could do this, because as you know, with distributed healthcare delivery being the responsibility of counties in Kenya, you have to get the county level ministries to buy in terms of implementation. Are there any questions or comments anyone would like to add? Please. And if you briefly introduce yourself as well. Thank you.
Hello, my name is Wagane, from Edinburgh Napier University. My question is, as you have just said that ICT for development, there is a research gap. And then you have mentioned about health information systems. Does it really include some monitoring systems using ICT for these? What are the visions in terms of which area you want to really research about?
Okay, basically, this is, you can see this is ICT for development, and it is general because we are said, as I said, it's transdisciplinary. You realize that we have experts from different domains. For example, we have doctors. We want to accommodate doctors, public health people, ICT people, engineers. Actually, now we have someone from mechanical engineering. So when it comes to designing an intervention, then at least they are there to advise on how we have to go about designing an intervention from the engineering perspective. We have social scientists who are supposed to look into the aspect of the social interaction issues, culture of people, and all that. So we are actually coming up with a framework that can be used to come up with not only the ICT, but a generic framework for the African context. So that irrespective of what kind of intervention you are coming up with, provided it's within the health space, it actually complies with that particular, because any intervention has to be context specific. Yeah, but for me, I am an ICT expert, or my background is ICT, so obviously I will represent the ICT fraternity. If we have the public health, like now we have quite a number of public health experts, they represent the public health fraternity. That's why it is transdisciplinary, so that then we come up with interventions which are balanced. Yeah.
Thanks very much, Andy. That was very good.
Thank you.
But just the sooner you engage with the ministries of health in those countries, the better. Isabel? So Isabel is going to discuss supporting well-being, a digital intervention model for disclosing sexual harassment in higher education.
So, thank you very much. Hello, everybody. So you must be wondering why I'm in this conference, because I'm going to talk about something that happens at my university in Switzerland, and we are here in Africa. I will tell you why at the end of the presentation, because there is a strong link, and you'll see how those two worlds are connected, but it's not obvious when you look at the title of my presentation. So how do I do that? Where is the, I go enter? Okay.
Perfect.
So this is a brief introduction of what I will talk about. I'll have I will introduce you the subject, then I will explain you the problem, then I will give you the research objectives that we had, then the approach, and then the preliminary results that we found. So the problem is that sexual harassment in higher education ranges, as you can see, from 11 to 73% for heterosexual women, and from 3 to 26% for heterosexual men. So it is a problem for us in higher education, and those numbers, of course, have been taken from studies in the Anglo-Saxon world. So we don't have a world study, but it's mostly the most representative research data that I could find. So the consequences of sexual harassment are that it affects your well-being. It can lead to a lot of disease and mental health problems. And it also, as I say, affects everyone. So we always think of the survivor. That's how the literature now calls the victim. We've changed from victim to survivor. We can debate that, but that's the common nomination now. The bystander and the work group and also the entire organization. So what does it mean? It means that it also affects the university. That's why university now as a whole are really concerned about this problem. So, okay, there is sexual harassment, but the real big problem is the underreporting. So all this presentation is about how can we engage people to report something that is very difficult to report because you fear for the consequences of, you may lose your work, you may have your supervisor having sexual harassment with you, so how would you be trusted and how would you deal with the situation? So we came up with this idea that maybe a digital intervention could help to disclose. Why? Because it's anonymous. So all our idea is that digital solutions have this fantastic tool, which is anonymity, and it's always referred as a very bad thing. You know, we think about cyberbullying where people are anonymous, but we never think about the upside and the good side, that actually anonymity could allow people to disclose things without being noticed and seek for advice. So this research was not to, because we are at the beginning, we've realized there are no applications that are applied to the higher education, that no universities have taken the step, so we were without data. So we said, okay, we're going to do a model, and we're going to set up the basis of how would be the best way to build this application. And then that's what I want to experience, and where I want your feedback is on what you think about our model. And then we think that could be applied somewhere else. So the way we designed this model, it didn't come up out of my head. It came up out of 3 different studies. One conducted in the school, actually, with the task for harassment that was put in place by the school. So we had all the stakeholders from the school, students, management, professors, everyone was in the task force, and we discussed how to do this. Then we have 2 ongoing researches in Switzerland on school bullying. So it's not exactly the same subject, but it's still the same idea. How would a kid go and say, look, in my school there's somebody who's really nasty to me and he's bullying me. So it's always the same idea of anonymity, and I promised you that it's linked to Africa and that it's linked to you, because this problem actually was not first raised in my research in Switzerland. It was raised by a Swiss organization Swiss international organization that was created in Switzerland, which is the International Committee of the Red Cross, who once came to me and said, we really need a push in gender-based violence. We really need to know how we can help more gender-based violence, and we think a digital solution would be the good way because victims are not disclosing gender-based violence. And then they started to show me some material, and then they said, and we have another problem, is that actually the people, if you do a digital solution, most of our clients, as we would call them, they don't know how to read and write. So you'll have to do a digital application that is something with drawings. And the project was really exciting, and we were really happy, and then change of management, project closed, and we couldn't go on. But the idea, and that's what I want to say to you today, is that anonymity in whatever gender-based violence you experience is a key, and whether you are in Switzerland or if you are in Africa. And that's where we need to think together of how we can do. And as the previous presentation said, within the context. Because if I take back my example of gender-based violence, they came up with images from different parts of the world, and they said the images of violence in a certain country is completely different to the images on another country. And so you have to adapt your digital solution to the context. Okay, and that's the most important. I come from social sciences, so I would tell you 100% this is important. But you can still have a model, and that's what I'm going to show you, where you have some common grounds. And where you can, if you address all those dimensions, then you can find a solution that's adapted to your context, but still has a reflection. Of course, this model can be changed, and we applied this model to our context, which was a higher education university. And in a nutshell, I will explain you what is the model. You can see there are two places. There's a human disclosure, so that will be the human side of the application. And down you have the digital affordance, what we expect from the digital tool. From the human side, we realized that anonymity, that's what I'm talking about since the start of this presentation, is key. We question uni or bi-directional anonymity, meaning the disclosure person would be anonymous, that's for sure. But does the person who answers needs to be anonymous or not? And the question was, within the school, sometimes yes, sometimes no. Because sometimes then the name, now especially with Twitter and everything, you could take the response, tweet it, and then the person who responded from the school or from the community would be having a problem. So this is something that needs to be discussed in your model if you want to have an anonymous. Is it both ways or is it just one way? On the other hand, you would be happy to know who is answering to your question. Is it the medical doctor? Is it a psychologist? So this is something we couldn't decide, and it would be up to the context to decide. The agility is a very big novelty. Every app I've looked at, they talk about the survivor, so the victim if you want, the bystander, but they never look at the perpetrator. The perpetrator is totally excluded of the model. And you can think, especially now in Europe with sexual harassment, that maybe some people are just not knowing if what they did was sexual harassment or not. They are very afraid. They would ask a question and they would need an answer. So we had this idea that the model should be, should be inclusive. I said agility, it should be inclusive, and it should include all the stakeholders, and which this is a big novelty, as I told you, because normally the perpetrators is totally out. The last part is agility, which means that the model should also be agile and decide whether it's good to know the role. So if I take my context in Switzerland would be, is it wise? I don't know who you are, but I know you are a student. And this, for example, from a university management point of view, is very important because the help you get as a student is not the same help you'll get as a management person, is not the same help as an academic, because we have different structures. So the system should be agile enough to say, okay, in my conditions, it's very important to know your role, student, not student, management, not your status, and the cases. Because do we have to know or not what exactly you're talking about? Is it sexual harassment? Is it violence? Is it bullying? So this is very important. And then you have the three other digital affordance, which are much more for the ICT people. I'm not an ICT person, so I will not go into details in those three important features, except that, of course, integration is, I think, key, and privacy is key. What I talk about integration is just that if you have an app that says harassment app, nobody will go in the app. So we decided to put the app in the student app, which is the EPFL campus app. And then you'll have within the app something that is about harassment, because otherwise somebody can take your phone and say, you have an issue with harassment. We can see you have downloaded the app. And then, of course, the privacy and the confidentiality is also key. But, I mean, we don't know who you are. It's anonymous. So we don't have the data protection issue, but we still have metadata that are taken. And this is a management that where we propose to have just erase the conversation or have the conversation just in the iPhone of the person who disclosed so that it stays there, the data are there, or aggregate the data to have still an idea of what's going on. But those are solutions that we address, and that would be, of course, dependent on the context and the solution you choose. Unfortunately, our school decided not to apply for how do I say that? For legal reason, we could not collect even anonymous information. So we had to withdraw the project. So for us, it's very difficult to evaluate the model because we couldn't test it. But we have an idea that it's a good model because regarding anonymity, because we've seen that Ireland has suggested a model that you can go on. It's called Speak Out. If you go on the web and you click Speak Out, you'll see that they are also talking about an anonymous disclosure for, I think, 7 universities there. Thank you very much. I'm done with my presentation.
Thanks, Isabelle. I think this is a very interesting and obviously a very, very challenging topic, not just in Switzerland or Ireland for that matter. And I thought it would be interesting for this community to have some exposure to some of the actions that different stakeholders are looking at to deal with these issues. So this is to stimulate discussion. Would you like to talk to us briefly about some of the ethical challenges that you may have come across in this? Because obviously there are advantages in this context, particularly between power displacement relationships of somebody who's more powerful and somebody who's less powerful. So the anonymity makes perfect sense to me. But at the same time, these kind of things can be potentially abused, you know, through false claims and things like that. So could you briefly comment on that?
Yes, so the idea is the digital solution is just to open the door. It's the first step. It's to disclose. And then the app is human-centered. So the idea and the research shows that you have to talk to someone. So at some point, the person online would say, you know, look, it looks quite important what you're going through. Let's have a meeting. And then we were delayed in the project for 18 months because you need to have the support system. The app cannot do anything without any support system that would vet every step of the way.
So in other words, there's checks and balances built into the design. So
yeah.
I couldn't say something nasty about somebody that isn't true.
Yeah.
By the stage it would go through a stage of verification, and at that stage my privacy would be protected, but at the same time I'm not anonymous anymore, except to the outside world. You know,
Yes.
there's an interaction going on with.
Yes, we because you cannot have an AI answer to those problems.
Well, you could, but I don't believe you should have. So I agree with you
Could,
philosophically.
but I mean, you should not. That's what I meant. Yeah.
Right. Are there any questions or comments? Chipo.
Yep. My name is Chipo Kanjo, working with University of Malawi as an associate professor in computer science. Thank you. It's quite interesting because, and I just want to agree with you that it's not unique to Switzerland. Currently, one of our final year students groups are working on a project similar to that. And they were debating whether this would be feasible. So as you were presenting, I just sent a message to that group that somebody is presenting here something very similar.
And there's a model in Ireland that at least you could look at and adapt.
Okay, yeah. So I would be quite interested to learn what were the challenges. Was it that the society didn't approve of the project, or?
Do you mean my school? Why they
Yes.
didn't go on with
Yes.
it? Was because legally in Switzerland you cannot take data, and we said, but We don't know who is giving the data from students, because at first they were really looking at students for prevention. They said it's not intervention, which I disagree. They said it's prevention. So you are not allowed by law to have any data of a student in a prevention because the case has not been certified. So they would range it as prevention.
Okay, it would be quite interesting to talk more.
Hi, my name is Ogane from Edinburgh University. Thanks, Isabel, for interesting topic, very difficult and challenging. There is in Edinburgh something similar research has been conducted, but it is regarding on bullying. But what they did was they just did this poster, a cubicle in the toilet cubicle, they put it there where people really leave a message, and the researcher will go back to really ask a question whether they want us to expand more or talk to somebody else. So there is a sort of a conversational thing where people are really volunteering. Most probably, this might be one idea to try.
So we had that in a school, actually. We were exploring that for kids, and they said it's worked perfectly. They don't have it in the toilet, but they have a box where they can address their problems. So we realized that a digital solution was useless because you have physical solutions that work perfect.
Yeah, please, if you just pass that. And again, if you need to
Thank you. My name is Benjamin Akimoje, and I wanted to find out from you, because I did something similar to this, where respondents were willing to discuss anonymously their conditions. And so the issue hasn't got to do with harassment, maybe like mental health, stress, but people are comfortable having conversation anonymously. So my question now is, if the issue has not got to do with something that has some implication like crime, or would it have been okay to collect information? Would there have been any ethical concern about that?
No.
Okay, thank you.
Anyone else?
Thank you.
I'm glad that you brought up this important topic, and if I can do anything to facilitate any networking of stakeholders who are interested in continuing the discussion, I'm very happy to do that. Okay, so Restituta. This one. Hi, how are you? Right, so which one is yours? Second.
It's okay. Yes.
This one? Perfect.
Yes.
And then to move the slides, you just press the arrow. Okay?
Yes.
Right, so Restituta is going to discuss usability evaluation of the user interface of the hospital information system for the Fistula program, a heuristic evaluation. Thank you very much.
Okay. Thank you very much. Good afternoon. Yes. I'm just going to deal with those 5 bullets. Discussing about usability of evaluation of the user interface of the hospital information systems for fistula program at CCBRT in Tanzania. So the reason behind is that obstetric fistula is one of the main serious I can say in Tanzania, which causes a maternal mortality globally. But in Tanzania is reported as 21,500 to about 2,500 up to 3,000 reported cases in each year. And the main reason is that lack of awareness about the disease and the treatment itself. So the expenses which cost, including the transport cost, inpatient accommodation, because most of them comes from the rural area, so the accommodation is during the treatment is also a problem. But globally, 2 million is estimated to be reported each year. And in sub-Saharan, we found that 30,000 to 1,030 is reported as a problem. So HIS, we say, is one of the tools which can capture, store, and process the data, and that can make the process of medication and the health in the hospital to be a bit simple. And we see that effective HIF implementation can be one of the solutions in the burden of populated people who are suffering with this problem. But also the effective health data collection is also very important, as it helps to utilize those data and save the affected populated. We have different advantages in the HIS. One is automating clinic administration processes, and it facilitates speeding of medication after identification of the patient. And that one can also help in one department from the hospital to communicate and get the patient to be helped and get the medication after getting to the hospital. So one of our main objectives was to assess the usability of the hospital information system at CCBRT, which is in Dar es Salaam in Tanzania, whereby we recruited 3 research assistants, and those ones are the ones who were used to evaluate the system, and they all passed the theoretical and the practical usability engineering course, and they had experience with the usability evaluation method. And later on, the system administrator at CCBRT oriented the elevators to the user interface of the CCBRT hospital. So the 3 evaluators later evaluated the system independently, and we evaluated the inpatient and the outpatient, whereby we also dealt with the outpatient module, laboratory module, pharmacy, inventory, and store management. So we collected the data by using the 2 checklists of Nelly's heuristic evaluation to evaluate the system of usability. After the data which we collected, we used the Microsoft Word, Microsoft Excel before putting the data into Stata. And we analyzed them. We considered also the validity and reliability of the data before evaluating the usability system itself. So the 2 different methods for analyzing the system, which was usability and the severity, were also, we used them. And we used the Crowbatch Alpha to assess whether the data the items were consistent with one another, and they were all greater than 0.7, which was reliable. So these were our results, whereby like the privacy heuristic was the highest usability problems, which was 100%. That means all elevators scored the same result. And that was followed by matching, which was 94 points. And the authentic, which was 90.8. So the maximum score, mean score of severity was flexibility. As I said, the data, we collected them from clinical and non-clinical staff after evaluating the system. Regarding the usability of the user interface of the fistula module, the problem of privacy also, we see it was 100%. That means we found that it shows really there is a problem there. So the average of severity of the problem related to the user interface was measured for flexibility, which is called just 1, and documentation is 0.76. So at last we found those findings imply that HIS evaluated was weak in terms of usability, which might lead to the low usage of IS, information system, addition to limiting the user conceptiveness of the system. In conclusion, we just find that in future, we need to deploy large number of evaluators, and we'll have to recruit them for those who have got a computer background and those without computer background. And but they will need to have a related requisite expertise to compare the result and accordingly further improve the system of usability features. Thank you very much.
Thanks, Mr. Chusha. I think that everyone would agree that fistula is a very debilitating condition to have to deal with. So what are some of the implications of what you're talking about? Who are the types of people who be using the particular HIS system? And what are the implications from your point of view of the feedback that you got through this analysis?
Okay, thank you very much. The people who are using the system at the moment are the staff of the hospital. Most of them are the staff of the hospital. They do go to the village and collect those mothers who are suffering with fistula, and they do have the, can I say, laptops, tablets. They collect all information from them. And after collecting the information, they send it to the hospital. And in the hospital now, they start from the first point of putting all those information in one section to another until now they call them by phone. Please come to the hospital. And they do send some money for them to take them from the rural area to the hospital. So when they come to the hospital, they find that their names are already there. But for them, they don't use system. They only use the mobile phone. Yes.
And then just to clarify, in terms of usability, was the primary problem identified at the hospital level interface, or was there also a problem with data collection at the rural clinic level?
Both sides.
Okay.
Yes.
No, thank you very much. Any questions or comments? Please. Thank you.
I'm very
Isabel, would you introduce yourself as well? Thank you.
Doesn't work? It works?
Yeah, it's working.
So I'm Isabel from Polytechnic Swiss Institute of Technology. I'm very interested in your research, but can you show us? Is it possible then to see the user interface, the design?
Not possible because I'm not at the hospital. I come from the Muhimbili University of Health and the Allied Sciences, but the user interface is at CCBRT Hospital, where we went in to do the research, yes.
Well, what we could do, Isabel, is if you contact me, I can put you in touch with Restituta, and then if you're interested in exchanging, that would be potentially a good opportunity to look at how usability skills available through EPFL could be applied in this case as well.
Thank you very much, Paul.
Well.
Thank you.
Anyone else? Thank you very much indeed.
Okay, so Joseph,
and then you just press this arrow here to move the slides. Okay, sure. So Joseph is replacing Wilfred today, and he's going to discuss making data talk using scorecard for strengthening data use at local events. Or local levels, I'm so sorry.
Yes, thank you, Paul. So I'm here to represent this paper as a research paper that I think we were supposed to be represented by Wilfred Segnoni, who was a read on this, with conjunction several co-actors, co-researchers. Most of them are from implementation side of things, and some of them are just for development part. Starting with Wilfred Segnoni, John Blah from University of Oslo, John Paul, and Venust from East Rwanda. These are from implementation side of it, but from technical aspect of it, we are myself, Joseph Chingaro, and Jeff Tenko. Starting, I think we say making data talk, using scorecard for stressing data use at local levels. Let's give him past background on data collection part. We know HIS, health information system providing several information that can support decision making at different levels. For example, patient current management levels, health unit management level, as well as system management levels. But however, even if it provides some information can be used for decision making, there are several challenges that we're still facing. One of them is low data quality, system being fully fragmented, and sometimes between stakeholders they are not coordinated at all. So that means there are a lot of data that are being collected, but there are little action at all. So what is motives that lead us to conduct this research? Is to understand the interventions that gear toward strengthening data uses at subnational levels. This must include district and university level. And our research citing, we cite at Rwanda, particularly for immunization program at Rwanda. So through this motivation, what we aim mostly to provide data use at local levels that improve data management and health information system at large, and also provide availability of key indicators and data from national routine to local health managers and health workers. Our core objective for our research is to understand the better intervention that enhance availability and use of data at subnational level, as I say, is mostly specific to district and national level, through implementation of scorecard. Of course, the digital scorecard one. So I think some of us are still wondering what is scorecard means, look like. So practical scorecard is just, it tries to represent key performance indicators in colored tabular form, so that it is to keep, we know people when you see numbers and see colors try to interpret it more on colored than using numbers. So this digital solution practically use some colors to indicate based on performance of given indicators. So most practical usage is used from some lighting color, green, yellow, and red, but depending on some implementations, they use to extend some other colors. For example, in this one scorecard that we used for epic coverage at Rwanda, so for their side, if you see green, means you are in track or you have achieved some target. If it's yellow, means you are somehow progressing toward to achieve the target. And if it's purple, means somehow not on track, but you need to keep up the speed. Similarly, if it's red, means you are poor performance, you are out of the track of it. So in Rwanda, so what they do, they usually have some coordination meetings that are happening on monthly basis, and participants are usually from all district health facilities for try to project. So they use this scorecard, that is, they use the scorecard to project and discuss the data. For example, you can see on those rows represent some facilities across, based on, and the columns represent some indicators across periods, I think based on quarterly basis. So practically they use, through this can discuss and trying to identify some gaps so that you can try to make some decision according to it. So even this one helps them to highlight some achievements against some targets that have been set, so that can be able to even compare between two facilities, at least to make some intervention on that one. So on our research, we use action research approach. That is, we plan, act, then reflect. On plan side, we try to recognize the problem, then try to make some action plan on it, and try to implement tracking of those actions that have been planned, and later on try to evaluate and try to specify what is the lesson learned from throughout it. So most of the research that we've done throughout this one is in cut across from all stakeholders, even during the implementation of scorecard, used through the same cycle. And not only that one, there's some engagement on some HISP network, mostly on participatory approach, at least to conduct some meeting, at least to share some lesson learned, even identifying some new needs from the community, and try to get them in the same cycle, at least to implement it so that it can avoid achieving something. So outside of this one, there are some major outcomes that have been achieved so far. One of them is promoting local availability analysis and use of data through scorecard. And this one, that's, I think previously shows some of the screenshot of the scorecard. It's from low level who are someone have some low skills on data analysis. They usually say it's user-friendly interface, and without even some skills, you can be able to use the scorecard and try to transform those routine data into some meaningful information for decision making, even at local level, means mostly facilities and some district levels. And also, through user, it facilitates sharing from performance indicator with key stakeholders, which provides some evidence by discussing during coordination meeting, so that can identify some poor performance indicators so that can plan accordingly. Also, other areas that have been outcome of this research is anchor intervention within local practice. As you can say, most of this through these coordinations, they use this through scorecard and try to analyze and review these data. And most of this, they are on their local practice during the coordination meeting. The usual scorecard, you pay the great law, at least promote further analysis information and provide informative decision making. As outcome of it is innovation implementation through action researching. So this is through engagement of different stakeholders, practically from implementation-wise of this scorecard. It's included from some new understanding of new requirements, even development, testing, as well as deployment, the implementation at your side. So through this one, it encourages ownership among stakeholders and on implementation and adoption of this scorecard. And also through this, it provides some experience sharing across stakeholders. The other thing is on regional collaboration and sustainability. For example, before implementation at Rwanda, there are some from Tanzania. They implement some of the scorecard at Tanzania MOH, as well as some on the regional EAC. So through that lesson learned, they try to at least to provide some lesson learned to ISPO Rwanda, so that can ease the process for implementation of scorecard at Rwanda. So through this engagement, I think there are some discussions that have been happening. So through the engagement, at least on the global perspective, we discuss most of the needs that have been at the local levels, trying to validate and to prioritize on how best we can plan for development. So through this, some local need ensured relevant to implement across some regions. So through designing this implementation of intervention, address the challenge of data use and analysis at local level, that make local level data easily available to users. Also promote awareness and discussion and analytical approach to monitor and evaluate health service performance, and also building local capacity to analyze and interpret data using digital tools. And also the scorecard approach may be useful in guiding and focusing discussion key indicator and monitoring, plan targeting contribute to better informed decision making. And lastly, this research contributes to existing literature on data use that by illustrating how useful data can be made available to user in ways that enables discussion and analysis. Thank you all for listening.
So I noted that data managers love the scorecard. But how do district health managers and how do local facility managers like the scorecard? Would you like to comment?
So, practically, I think based on those meetings that have been said, at least it's previous, they don't know how they be performed with different indicators. So through user, at least scorecard it just giving flexibility. It depends on your levels. So even at facility, you can just compare yourself on the nearby facilities. So at least for your during the meeting, at least you can just transfer through what lower level at facility level and try to cross-check throughout the meeting, trying to discuss and get some data gaps or achievements throughout. So at facility level, you can just compare toward one another and try to learn from others why they perform better from others. For at the district level, try to oversee at least all the facility, how they perform, or even across other facility, how they perform, so you can try to learn from others to implement on your facility or on your district levels.
No, I understand entirely that it can be used to compare performance. I suppose I'm looking more at the human factors. You go to your meeting with your peers from other clinics in your district, and your performance is here and their performance is there. You know, how is it used in practice in terms of helping people who may be underperforming or maybe having challenges? You know, in your paper you noted, for example, that sometimes the data can be misleading insofar as, depending on how old the census data is, for example, the projections for vaccinations, for example, may be more optimistic than reality. So you're hitting reality, but the statistics say you should be higher, therefore you're underperforming. But you're not really, because the statistics are wrong. So I'm just wondering how you deal with situations like that.
So practically through discussions, at least if you go performance is too low, they try to discuss across what is the really critical cause to that. For example, sir, in some of the use cases that attempts we discuss with some of the facilities. So because of some projection statistics, it is that some result is poor, but the actual population is just low. So they try to study and go to the root cause of why the data is too poor and try to get the mitigation of that one. So to try to change even the target for population.
And then my last question before I open to the floor is, how easy is it to understand, for example, if I'm a district, if I'm a facility manager and I'm yellow for something, how easy is it for me to identify what is the key factor within my performance that would allow me to go into the green or allow me to go into the purple?
Practically, there's some predefined indicators that have been known throughout the facility and how been calculated. And knowing the colors is based on some ranges that have been agreed throughout the facility or throughout the district. And if we perform low, it just automatically gets you. So practically this digital solutions just try to digitize the actual process that have been currently, there was previously being used
manually. Yeah, no, I understand. Okay. So anybody have any questions or comments? Please.
Thanks. Apologies. More of a clarification, and apologies if you mentioned it there, but is the scorecard coming directly off the DHIS2 data?
Yeah, this is DHIS2.
So it's coming off DHIS2 data.
Yep.
And is it a report in DHIS2 which is then printed out, or I just want to know, is it a paper copy that's used in meetings like that? How's it actually produced, the scorecard?
Okay, so
sorry, the reason I'm asking that is more or less, to find out whether you can drill into it. If it's a digital cube in a...
if it's paper, you can't. I understand.
Yeah, exactly.
Sorry, would you introduce yourself?
Sorry, my name is Chris Seavrex from Jembe and the University of Cape Town.
Thanks, Chris.
Okay, thank you, Chris. So, practically, I want to add more question? Oh,
Answer his question. Then
okay, sure. So, practically, even in Rwanda, the routine data they collect and use DHS2 practically. So they collect different kind of data for immunization purpose. So practically what scorecard does is just try to, based on predefined indicators that have been defined on the system, you try to populate and try to arrange them on the carabel. So during the meeting, practically they use to project on the projectors, they try to project the scorecard for a given district that you want to discuss, so they try to predict. But it's possible you can try to download and try to send for other people. It's some of the functionalities that we add. But during the meetings, they use to project, like this is the meetings for districts, they try to project on the board and try to discuss from there.
Does that answer your question, Chris?
Yeah.
Perfect. Okay, so
Ogane from Edinburgh University. Thanks very much for a really nice talk. It's not a question, it's just a comment. It's really based on Paul's suggestions. In the United Kingdom, there is a sort of a track where people, when they go to accident and emergency, they should be treated in 4 hours. And then if it is not, when the figure seems very bad, when 50, 60, 70% of the people is not treated, then the managers start panicking and then start manipulating the numbers so that it is within that limit. And some even suggested that just get rid of this measurement for cancer.
and then there was a colleague in the back.
Thank you. My name is Benjamin. Thank you for the presentation. And my questions is almost to his cooking of data when it comes, because I was in public health too. So this was an action research. Did you find any case where people had to improve their data to make sure it meets desirable color as against, and if it ever happened, maybe if you notice any pattern, people with poor performance not showing up or at the meeting, that's human behavior, like towards reactions towards those scorecards. Did you understand what I said?
Yeah.
Exactly. If mine was showing green, I'll be happy to go to that meeting. But if it's yellow, or I might not want to go to that meeting. So I'm just wondering if you found anything like that.
Yeah, that's true. It's sometimes for example, you're just giving experience from Tanzania. Practically, you have to first of all to acknowledge whatever the result it is. That's what they do. From there, as I say, they try to try to know the actual problem. What is sometimes do data quality, or perhaps the data entries who do data entries is mistaken. So, as a follow-up from those meetings, if they suspect it might be on concern some data quality, most of the time some team for data quality teams try to go on the facility and try to verify the data, then try to check if there's any improvement on the scorecard. So, of course, nobody like if you get some yellow, some red or purple, but you have to acknowledge and try to get into root, of course, what is the cause of it. So at least you can, if it is not a quality, at least it can help you to learn from others who will perform better and so that you can try to improve on your side.
Everyone's speechless. Just thank you very much indeed. And last but not least, come on, you know you want to talk. So is this your last one?
Yes.
Perfect. Okay. And then here, and then...
Does it have a pointer?
Yeah, it doesn't have a pointer, no.
Oh.
Well, you can use pointer like this if you want to, but to move the
doesn't
slides...
show over there.
Oh, then I'm sorry, it doesn't.
Oh.
And then you just use this to move, okay?
Thank you.
So to be ready, let's go to discuss synchronous teleaudiology, school-age hearing screening in a low-resource community in Cape Town.
Yeah, okay. So this is my very first ever academic conference, so excuse my nervousness. So I noticed in the audience a gentleman wearing a hearing aid. Yes, yes. So I think we can all agree that it was through hearing sensitivity combined with technology that the world remained connected during the COVID-19 lockdowns. Additionally, the COVID-19 pandemic led to the wearing of masks and social distancing, which negatively impacted people with hearing loss. Due to universal masking, effective communication and patient safety were compromised for individuals with hearing loss, who could not understand attenuated and distorted speech or gain clues from lip reading and facial expression. Like Sir Paul said there, my name is Tidire Deng. I'm from the University of Cape Town, and this work came from my Master's in Health Innovation, which I've just completed. According to the World Health Organization, more than 2.5 billion people will have acquired hearing loss by the year 2050. As a result, rehabilitation services will be required by over hundreds of millions. South Asia, Western Pacific, and Sub-Saharan Africa are the most affected areas by disabling hearing loss. Ironically, the majority of those with hearing loss live in these low-income countries. Figure 2 on the screen compares the total number of ENT, audiologists, and speech therapists in South Africa in the year 2009, 2015, and 2018. Note that there is a decline between 2009 and 2015 in the number of audiologists in South Africa. However, a study conducted in 2018 revealed that there were 623 audiologists with 1,548 dually qualified audiologists and speech therapists. It is therefore impossible to predict the future based on fluctuating evidence, despite the rise of audiologist professionals you see in the country in the year 2018. In addition to these numbers, these numbers are still insufficient to meet the needs of the South African population. In addition to lack of human resource, many countries have no policies that support access to hearing care. The public at large and policymakers are unaware of hearing difficulties and how these difficulties impact the quality of life of people and its management costs. As a result, hearing healthcare has not received the attention and resources it requires. Despite the importance of hearing rehabilitation technology, only a small number of people with hearing loss can access these devices and the necessary support and services. The development of digital health interventions, that is DHI, holds enormous potential. Due to difficulties accumulating knowledge about DHI, the potential of DHI has so far seldom been realized. In addition, the technology landscape is changing at a rapid pace, which requires DHI to continuously adapt and be updated just to be useful, let alone improve. It is important that researchers create an actionable knowledge base that can assist the public, patients, clinicians, policymakers, and healthcare commissioners in making decisions regarding DHI by identifying the most cost-effective, safe, and scalable interventions to improve the health of individuals and populations, leading into the aims and objectives of this study. The aim of this study was to establish the equivalence of synchronous teleaudiology hearing screening and in-person hearing screening in school-aged children in a low-resource community. This aim was achieved through the following objectives. Objective 1 was to conduct in-person and synchronous teleaudiology hearing screening and compare the results to determine their concurrent validity. Objective 2 was to conduct network testing to establish the best network conditions, hence the feasibility of the teleaudiology solution. And lastly, the objective was to compare the time of in-person and teleaudiology hearing screening. This study used a cross-sectional study design with a within-group comparison. This means that the same group of people underwent two different types of hearing screening, one in person and the other one via teleaudiology screening. The target population and location for this study were that representative of a predominantly low-resource community, where access to health services such as hearing health is limited. Participants came from Ntwasahlobo Primary School in Khayelitsha, Site B, in Cape Town, South Africa. Ntwasahlobo Primary School has a very progressive educational atmosphere and was chosen for this study because it is representative of a realistic rural school environment. Sorry, I'm very nervous. Okay.
Our part is over.
We used non-probability purposive sampling, that is voluntary response. 50 participants were tested that made 100 years and ranged from 5 to 6 years old. So all these learners were in grade R. Ethical approval was granted by the University of Cape Town Faculty of Health Sciences, Human Research Ethics. Procedure, the data was collected in two phases. Phase 1 consisted of on-site hearing screening, while phase 2 included two sections. The first section was network testing, and the last one was synchronous teleaudiology hearing screening. Instrumentation. Both the audiologist and the participant sites were equipped with Windows laptop with built-in webcams. TeamViewer software was installed on both laptops. TeamViewer is a remote access, remote control, and remote support solution that works with almost every desktop and mobile platform, including Windows, Mac, Android, and iOS. With TeamViewer, users can remotely control a computer or mobile device located anywhere in the world and use it as if they were actually there. Assessment of the tympanic membrane was conducted using the Kuduscope digital otoscope. The Kuduscope is a PC-controlled digital otoscope and mini endoscope that offers users a clear view of both the ear canal and the tympanic membrane. This lightweight, pen-sized digital otoscope enables clinicians to conduct ear canal and tympanic membranes examinations and investigate symptoms regardless of setting or location. Since the Kuduscope, otoscope, and miniscope does not require an internet connection, users can annotate images and take clinical notes offline. The KuduWave 5000 prime audiometer with insert ear tips and calibrated supraoral headphones was used to conduct hearing screening. This audiometer was connected to a Windows laptop running the Imoyo EMR software. This equipment is a portable audiometer featuring a boothless design for precision audiological screening. And the Ambidome noise cancelling technology in this audiometer allows for hearing tests to be conducted in a natural environment, thereby eliminating the need for static hardware and soundproof booths. The device allows pure tone and air conduction for high-volume industries, schools, and wellness days. The audiologist who was situated at UCT and the research assistant situated at the participant side were both connected to a 5G RAIN network. The audiologist was able to gain control of the laptop running the Imoyo EMR software at the participant site. The procedure was as follows. Phase 1. Sorry that we don't have a pointer here. Okay. The procedure, so from the 50 participants, we divided them into first group 25 to go through the first test, and the other 25 did the second test first. This was done to minimize order effect. The site was Ntosatlobo Primary School, as mentioned before, using the CodeWave audiometer on a Windows laptop, did case history, brief case history with 5 and 6-year-olds. And we conducted the otoscopy examination, then participant prep, followed by instructions and conditioning. And the automated pure tone sweep, we tested 1,000 Hertz, 2,000 Hertz, and 4,000 Hertz, and 500 Hertz at 25 dB HL. Audiogram results stored and saved. Phase 2, Section A. To conduct teleaudiology practice, reliable and good broadband connectivity is required. As a result, network testing was conducted using the NPERF speed test application. The network testing was conducted at Ntosatlobo Primary School, the participants' local site. The tested networks were MTN on a 4G LTE dongle and MTN on 5G Samsung Galaxy A22 smartphone, and Vodacom on a 4G LTE dongle, and Vodacom on a 5G Samsung Galaxy A22 smartphone, and RAIN on mobile 5G network. Network testing at the audiologist site took place only on the network that presented good coverage at the participant site. Phase 2, the teleaudiology hearing screening. This phase involved interactive, real-time hearing screening conducted by the audiologist using a remote access and remote control computer software, like we've mentioned before, the TeamViewer. In addition to remote access, TeamViewer was also used for audio and video chat in this study. During the test, the trained assistant and the participant were situated at Ntosatlobo Primary School, while the audiologist was stationed in an office at the University of Cape Town, Faculty of Health Sciences, 24 kilometers away. The assistants at the participant's site performed the video otoscopic examination connected to the laptop at Ntosatlobo Primary School, which was displayed on the audiologist's computer simultaneously for diagnostic purposes. Using the TeamViewer application, the audiologist remotely controlled the hearing screening application. Thank you. Sorry, I was saying thank you too. Okay, the results. These were the otoscopic results that we took using the digital otoscope. Picture A, that shows a very healthy tympanic membrane, and B, a healthy tympanic membrane, with C showing an occluded tympanic membrane. Pure tone results. Now this is the screening. The side of the blue, that's the left ear. The side of the red, that's the right ear. Now this is the audiogram. These are the results that we obtained during the hearing screening. And they're showing normal hearing on both sides. Now the results for the network performance. The connection that we received on the 5G Samsung Galaxy A22 smartphone devices using both MTN and Vodacom was a 4G plus from a 5G smartphone, but the connection was a 4G plus. With the 4G LTE, the connection received was a 3G. MTN network on dongles and smartphone revealed speeds of less than 10 Mbps for both download and upload. The Vodacom network was no different, and the RAIN revealed download speeds and download speeds of between 100 and 200 Mbps, and upload speeds between 20 and 100 Mbps. And that is why we ended up using the RAIN network. The time spent during on-site hearing screening was equivalent with the time spent during the remote screening. That was 10:23 and 10:26 respectively. Mean response times did not differ between the right and the left ears during on-site hearing screening or remote screening. In the right ear, the mean response time did not differ between on-site and remote. However, in the left ear, the mean response time was significantly longer using remote screening at 500 Hz and significantly shorter using on-site screening at 1000 kHz. And these discrepancies came down to poor network setting, and because of our participants being children, they were very much excited with the technology, so they took longer to respond. And in conclusion, this present research demonstrates that school-based hearing screening performed in person and school-based hearing screening performed remotely via synchronous teleaudiology are equivalent. And due to its concurrent validity, teleaudiology is a reliable model of service delivery. Low-income countries may benefit from these findings that bridge the gap of a shortage of audiologists and increase access to and affordability of hearing health services. However, studies utilizing synchronous teleaudiology for hearing tests are very limited, especially in sub-Saharan Africa. It is therefore required to conduct further research on different age groups, and notably with populations with different degrees of hearing losses. And furthermore, the existence of reliable broadband connectivity is of utmost importance to the effectiveness of synchronous teleaudiology practice. And a number of studies that examine network performance in remote and rural areas should be taken into consideration as the world is rapidly moving to digital health interventions that require high-speed internet access. As teleaudiology developments are growing rapidly, research involving AI should be examined in upcoming investigations. Thank you.
Well done. And now the Inquisition starts. Okay? So the first question I had was actually in relation to the amount of time needed and whether you think less time would be needed with older children. I mean, I thought, first of all, that 10 hours seemed like a long time for 50 kids, but when you actually calculate it, it's 12 minutes a child. So it's not actually a long time. By the time they're getting used to the devices, you're explaining things to them, you're asking them questions, you're asking them if they're comfortable, they're asking you questions. So I can understand it takes time. But do you think that it's possible that with older children it would take more time or less time than with the 5 to 6 year olds?
With the older kids will definitely be faster than the younger kids, because with the younger kids sometimes we had to take off, put on again, explain again, put on, so it was like back and forth.
Okay.
Yeah.
Then the second question I think a lot of people would have, can you just go back a couple of slides to the one where you show the different, that one?
Which one?
This one here.
Yes.
From the work that you've done so far, what is the minimum bandwidth requirements to be able to do this online? Because I think many of us would agree that in many environments, hoping to get 20 megs, let alone 200 megs, is not really in our wish fulfillment whatsoever. So I'm trying to understand, in a different environment, you know, say deep rural Malawi, for example, where you're lucky if you have 3 or 4 megs in some places, you know, would it be possible to deliver this, and what are the trade-offs that would happen as a result?
I think the only way it will be possible to deliver it is if there is a base station closer to the area. For example, when we realized that Vodacom doesn't have the base station, and we thought Vodacom, because Vodacom is very well known, we thought Vodacom would be very good, but we found out that they don't cover that area, so they don't have a base station close by. MTN didn't have, but we're hoping to install one soon. So it will only work in a place where you're using the network that there's a base station close by.
Okay, and then my final question, I promise, before I open the floor, is do you think it would be possible to do this on 3G, or do you think it needs 4G plus?
5G. 4G might, but 5G is the best.
I know it's the best, but would 3G work?
No.
I open to the floor. Either you ask a question or I pick on someone. Thank you. If you wouldn't mind introducing yourself. Thank you.
Hi, my name is Carl. Thank you so much for the interesting talk and something that is very important to our people and Africa in general. Do you know if anybody is working on image compression? Because theoretically, with 8 megabits per second and 3 megabits per second, and you're having that very small otoscope that fits there, the resolution is not that high that you need to send. So I think with good image compression, we could do it.
That would only be for the otoscopy examination, would not work for the testing itself, for the hearing test itself.
But we also have audio compression.
Yeah? Okay, that is something new to me.
Okay.
Thank you for bringing that up, because that is a legitimate point. But the trade-off, as you understand, is the sensitivity of the data may be affected by the compression, and it may be affected by the available bandwidth at the level of sound and with the type of patients that we're talking about here. So I think it's certainly possible, and it would be worth considering. Any other questions or comments? Please. Well, potentially.
Yes, thank you very much. My very minor question is that what triggered you to to choose the topic and to select that particular audience? Thank you.
Yes, thank you. I'm an audiologist myself, so I don't think there's any question about that, the reason of the topic. But being an audiologist, COVID-19 came. Most of my peers were not working anymore. Honestly, there was just nothing they could do because it's taken as not life-threatening, so you don't have any work. So COVID-19, I think it's what made us go into this route, teleaudiology. And the audience, the kids. Yes, kids, because school-aged, hearing loss. If you go into school, you can't hear. How are you going to develop academically? Socially, emotionally, it affects everything. So it's important to test them while they're still young, especially when they're going into school, so that we know what we're working for. That's why we chose kids, and the grade R's for that matter.
So did that sound like a master's answer to you? No. That was a good answer. Anybody else before we close? In which case, thank you all very much. I think you'll agree we had a very diverse... Oh, sorry, do we have somebody? Please, thanks. Appreciate that.
Hello, I'm Yuri. Wanted to ask and also comment. I understand that you moved to tele because it's, you can communicate over distance. But I was wondering whether you could try and use more of edge instead of testing. Instead of having to test over the net, you test on the machine and then you find out whether that works, because it seems like the bandwidth is more of the issue. Oh, and also if you get into AI, edge will also work better. Yeah.
Sir, I don't think I got that last part.
Oh, the last part about AI?
Testing the machine?
Oh, testing on the machine. Okay, I get you have to actually listen to the audio yourself to make sure the results are good. But also, I think it would also work in a way that maybe if you use some software to some level, it might work to just place the software on the machine, on the machine the person is using. Does that make sense?
Yeah, I think there may be a misunderstanding insofar as the software, as I understand it, was on the local machine.
Yes.
And then a remote control software package was being used to use that local application with the student, or the student, I mean the child, and then the remote audiologist was interpreting the results based on software that was working locally. So the software is always local, and they were using a remote control piece of software to be able to access it and to interpret it remotely.
Yes.
Does that answer your question?
That means that means you as the audiologist are the one who needs to connect to that other person's machine.
Yes. Okay. Because in this case, we're trying to see, can audiology scale? In other words, can you have somebody that can be trained to a certain degree, who can go to a lot of schools in quick succession, and then you have the professional audiologist remotely who doesn't have to take the time to travel, but can provide the service at a sufficient quality if the bandwidth available is sufficient to the job. And that's the disappointing challenge, and that's where our colleague was talking about the use of compression technology to see if it's possible to use lower bandwidths and still be able to deliver the service. And I think that's a legitimate thing for you to explore.
Yeah.
So could we give her a little round of applause?
Thank you so much.
So thank you all very much. I look forward to seeing you at dinner, which hopefully will start at 6. And then I look forward to seeing you bright and early at 8:45 in the morning, because of course you want to turn up early for your 9 o'clock session, don't you? Thanks, guys.